Thank you. As you can see, it's quite an impressive program, and thank you very much, because you are the ones who sent in all the papers and made this massive contribution. I just would like to say one thing before I introduce Chapal. There is a say that knowledge unites and builds bridges. And I think we here, regardless of our skin color, religion, or politics, is a true proof of that knowledge unites and builds bridges. And I think that is part of Chapal's talk as well, and you're going to get the proof of that. Chapal is not a person, just a normal person. He is a very normal person, but he's done a lot of things, I tell you that. He started off as a CPO and got that from Mumbai in India. He then worked in lots of different things in rehabilitation, community-based rehabilitation, and so forth. He worked himself in 7 different countries. He's been to, I don't know, it's like 70 countries where he go and lectures and tell people and inspire people what to do. He got a very nice position at the WHO since 12 years back, and I must say Chapal is one of ISPO's big supporter and have made it possible for ISPO to move forward as fast as we have done. You also have a master degree, of course. You also do a PhD, of course, something which I don't do. So, but congratulations. One thing I will just ask you to do, he's actually going to get a medal after this, but I thought you will be the judges. If the talk is not good enough, we don't give him the medal, so you're going to tell him what to do. Chapal, please.
Thank you, Ben. Good morning. Bonjour. Salam alaikum. And namaskar. This is a great privilege for me to speak about this revolutionary concept, the concept of this century, in front of you. And I thank Ben and the ISPO for giving us this great opportunity to present global cooperation on assistive technology, we nickname GATE, in front of you. And let's go through it. Let's open the gate. Why assistive technology? Many people will say, you done prosthetics and orthotics. Okay, I can understand wheelchairs, but why assistive technology? It's because to address the current and emerging need, to look beyond physical disability, in fact, beyond disability, to diversify prosthetics and orthotic sector, to be valued more and remain relevant. And why it is, you'll learn as I go along. To ensure the benefit of universal health coverage reaches to all, and to assist countries in implementing the Convention on the Rights of Persons with Disabilities, CRPD. So what is assistive technology? We are debating quite a lot on the terminology, whether we should say, is it assistive technology or assistive health technology? So there's a bigger debate going on with ISO and others, though we prefer to say it is assistive health technology. Whether many people agree or not, to WHO, it is a subset of health technology. And the main function of assistive technology to maintain or improve functioning. And we believe the providers are mostly health personnel. And that is why we say it is a health technology and the providers are health personnel. And it is beyond products. Many people confuse between the assistive products and assistive technology. It's more beyond the products. Assistive technology is more umbrella term for the whole provision, including scientific application. And when I say assistive products, I say a big range, okay? From the cane to orthosis, prosthesis, to even up to the robots. So it's a wide, big range. and why it is, again, you will learn when I talk more. Why assistive technology should be a global priority. Hey, this guy was talking all this time about prosthetics and orthotics or wheelchairs. Why he is talking about assistive technology? Why it should be a global priority for this century? There's a big difference between last century and this century if you see the health scenario and the demographics of the health scenario. The communicable diseases, like which used to cause major disability, especially in the low and mid-income countries like polio and all, is going down, and it will disappear soon. But road traffic injuries are increasing, so as non-communicable diseases, cancer, diabetes, and all are on rise. But whatever these health conditions will create, number of our future clients, that will not be really anywhere nearer to the group of aging. Aging will be the biggest factor of what we do today and tomorrow. And this will supersede all the numbers of the clients we see or we are responsible for. So 21st century is not only people, it is 21st century in compared to 20th century, is also about people living longer, irrespective of their health conditions. So health intervention system, the problem is the most health intervention system still are based on 20th century. It's mostly focused on preventive and curative measures, and little bit on promotive and rehabilitative. But this concept emerged in 1978, and we are today 2015. Can we go on with this concept, or should it change? And the change, what we are saying, that in 21st century, we should also add one more component of health intervention, which is assistive or supportive. Why it is this? As we age, we will lose functioning. What I am talking about, these assistive products, is not assistive products only for few 2 to 5% people with disabilities. It's for all of us. If we live longer, we all will be users of assistive products. In fact, my father, my aunties, they're using more than 2-3 products as they're 80 plus. So the concept of the 20th century is more based on the minus 50 age group. Because people used to die early, there is a huge problem of vaccination, immunization, and the treatment. But the current health intervention should be of 50 plus. In fact, 0 to 100 for all age group. So health sector intervention, policy, products, provision, education are still very much based on the realities of 20th century, minus 50. I do not know about this year conference, but up to last exhibition I saw, most of the products actually for minus 50. But the future will be plus 50. So the health sector intervention should add the assistive intervention, assistive products, and in fact go beyond classical disability, look at the whole functioning and go 0 to 100. In fact, I'm going 100 plus because some of my friends' fathers are already started living more than 100 years. So if you see the whole health concept of the traditional health products, of the last century of the traditional health products was medicines, vaccines, and medical devices. You don't have to go far. You come to WHO, 99% population is working on these 3 areas: medicines, vaccines, and medical devices. And I'm trying to make a case within WHO and within the Ministry of Health. In 21st century, it's not dying early. Maybe some countries still they die, but 21st century is also living long. And so we should have medicines, vaccines, medical devices, and assistive products. We need more products, more technology to live independently and productively. So this is the concept what we try to say in the WHO and the other members, that fourth pillar of the health products should be treated as assistive products, and health technology should embrace assistive technology. Now the changing disability scenario, pathology, perception, experience, morbidity, is unique what is happening now and what will happen in future in compared to last century. In last century, when I started my profession, we worked a lot on polio. Every day and night is to make orthosis. I do not know in numbers. But in 21st century, it's more elderly people. And more we go further, it's more elderly people. And the experience of somebody growing with disability and experience of somebody who is gradually going towards disability is quite drastically different. And we have to recognize this factor when we make our future planning. So as I said, the functioning goes down as we age, but there is a classical difference here. When somebody is disability and growing with that, except children with multiple developmental delays or cerebral palsy, most people with disabilities has a problem of functioning in single domain, either in mobility or in hearing or in vision. But when we grow older, we'll have a problem of multi-domains. It's not on single domain. Even if somebody is using wheelchair, as they grow older, they might have a vision problem, they might have a hearing problem. And more we grow older, more different domains will be affected. It's not anymore a single domain issue, it's a multi-domain issue. It's a question of unimorbidity to multimorbidity. So minus 50 is unimorbidity, whereas plus 50, we need to talk about multimorbidity. The whole scenario, we talk about multidisciplinary team, we really need to go much beyond our traditional definition of multidisciplinary team, because it's no more only mobility will be affected, there will be other parts also will be affected. The pace of aging, many people think, is a problem of the high-income countries. It's not a problem of the whole world. That's not true. If you see these statistics, France took more than 100 years for their aging population to become from 7% to 14%. But countries like Thailand, China, they're taking 20 years. So the people and the health sector, advancement of health sector, is also making a little bit different effect. So people even with a health condition, they cannot die. There's a good health treatment, good health intervention, they will live. So it's no more an issue of only the developing high-income countries. There's a very little gap between the low-mid-income countries and high-income countries. And the gap is getting reduced. And if you see the slide on the left, the photo on the left, a guy from India and the lady from the right, if you see both of them using more than 3 assistive devices. So we cannot say, okay, I take care of orthosis, I give you AFO, You go to another place for a wheelchair, another place for a cane, another place for glasses, and another place for the hearing aids. It's becoming impractical. This husband of this lady told me he spends 1 week of a month in different clinics. So why can't we think differently? More age, more assistive products, because we all will have multi-morbidity issue. We say more than 1 billion people now and 2 billion people by 2050 need assistive products. Are we ready for it? Is the industry ready? Even if you have all the money today, you cannot buy this many products. Neither industry is ready, nor the professionals are ready, nor the educational system is ready, nor the health system is ready. So we say only 1 in 10 or 5 to 15% people have access to this. And when we identify the major barriers, awareness, who knows the sector and its importance? Where is the evidence? Why the policymakers should invest in this sector? What's the return? And many countries, we just did a study, the many countries who ratified the convention, 70 countries has reported what they have done, and hardly there is mention of assistive technology. Forget about prosthetics and orthotics. Products, the quality products are overpriced, and affordable products are often of poor or low quality. There's no middle class here. So either you have a high end or you have to go a low end. There is very little choice in between. And the service provision is very segregated, isolated, and locked in big cities. So people living far from from the cities, they have bigger problem. And this problem is universal. America to Zambia, everywhere far from the cities, you have access difficulties to these products. And I also say that education, the current education, is not smart enough. It's still based on the realities of 20th century. It's definitely not for all. We need to change this scenario. This is all the background. What I gave is to change this scenario. And how we can change, this is all about GATE, which is a multidisciplinary platform for making a change. We brought different stakeholders together, industry, private and public industries, academias, users group, government, NGOs, UN, all together and creating this platform. And we have only one mantra or one slogan, how to improve access to assistive products. And I'm lucky, many people sell many things and I sell dreams. This is my dream. I sold my dream, and Rob was here somewhere. I can't see him, but Rob was the first person who bought this dream. And still it's a mystery in WHO, how come this guy on the first minute said, okay, I'll put $6 million behind this initiative. Let's open the gate. Thank you, Rob and USAID for this. But money alone cannot solve the problem, because we need people, we need networks. And the network who bought it most is definitely ISPO. Thank you, ISPO. Thank you, Bang. They really, from the day one, they are really embraced GATE and pushing it at every possible corner. So what GATE is about is focusing basically on 4 actions: how to improve policy through research and advocacy, how to make products more available at an affordable cost without sacrificing the quality. Third, how we can make the provision single window, comprehensive, one-stop, and national program so that people from the national capital to the community level, they have the service. And the fourth is the training, prosthetics, orthotics, wheelchair, and certified assistive technology programs. So let's go one by one action on influencing policy using evidence. You want to set the research agenda, encouraging research, and making professionals interested in policies and legislation. You know, many of you are great practitioners. Maybe you are playing some role in the policies, but not enough where it matters the most. Out of 8,000 WHO staff, we do not have even 6 rehab professionals. So it's less than 0.01%. So that means we don't give that much importance to the policy. But that's the place where we have to put all our investment if we want to change the world, if we want to see our products, our service are more in demand. So, and the research, when we say the research, you need to have the research at the 2 levels. One at the very broad, which can influence the policy, which can influence the national programs, but also at the same time, you have to go for a finer, sophisticated research. So the research agenda is first what we are going to invest in, cost effectiveness, return against investment. Why should people put money in this sector? Scoping exercise, modeling the future. Industry will never put money if they don't see the market. So we have to say, what's the market 10, 20 years down the line? Then outcomes and impact of assistive technology. And fourth, what is the role assistive technology play in aging and also the emerging AT sector? You will hear some more about when Mac will speak because he is coordinating this effort very much. And the fifth is the appropriate AT service provision, how we can ensure that people can access these products closer to their community. Action 2, making high quality, affordable product for all. I like pyramid, and if you go to Egypt, full of pyramids. But this pyramid is very unique. It has been beautified only that top portion, that 10%. And this is what the market is now. How we can reach to everybody, that's the biggest challenge, and that's what we have to do. So there's very little choice at present for the people, especially in the prosthetic sector. Forget about orthotics. Either high-end products like modular or ICRC or Jaipur. Why can't we have some more in-betweens so the people has the choice? It's a very familiar scenario of the past in the medicine sector. I think we are 30 years behind the medicine or pharmaceutical sector. They had the exactly same issues. A few companies, mostly for the population or country who can afford. And the industry's policy was higher margin, lower volume. Why to take trouble? In 1977, to change that scenario, WHO introduced the model list of essential medicines, which later has been identified a peaceful revolution in international public health. Can we learn something from this sector? It changed the market. Now most high-quality essential medicines are available at an affordable cost. And that's why people are living longer. They can access the medicines and they can access the medical intervention even if they have any health condition. So government, I don't put the blame on the industry, it's the system. If you go to any industry and ask them what is the maximum investment they have to spend, it's always in R&D. The same in the pharmaceutical sector. So the government invested in innovation, technology transfer, and absorbing the R&D cost. So many governments are putting money, saying, okay, we'll absorb the R&D cost. You pass the production cost and your profit to the users. And you won't believe, it reduces the product cost almost nearly 80%. So based on these success stories and results, we are developing the WHO model list of priority assistive products. Is developing a list of 50 priority assistive products based on systematic review, Delphi study, global survey, consensus meeting. To know more, you come to the session 51, so I'll not go more further on this. But it's a sample global survey. We'll put a global survey in a month time. And we'll put about 100 essential products in that list. And each of you have to choose 50 most priority ones. If your area is not covered in the list, don't blame me. If you don't go to the survey, if you don't take part, your product may be missing because there will be others, and this is a very competing list. Action 3, models service provision. Now, prosthetics, orthosis, wheelchair, mobility devices, why can't they work together? Why we can't bring them in one place? Even the low vision aids and the glasses work different. Hearing aids, communication works different. Can't we bring this together? Is it a rocket science? In a hospital, we have so many departments for different health conditions. Why can't we have the similar concept for assistive products? So it is more like uniting the fragmented sector to address multi-morbidity. And from this, what we are trying to see, identify which are the products with some training a community health workers, local nurses can give to the people. We have seen, due to the lack of providing even a shoulder sling after a stroke, many people develop a deformity. So why not we pass this knowledge, some of our tasks, to others so that people get service as soon as possible and closest to their community. And action 4, the most important, is the training. There is no alternative of knowledge. Please invest as much as possible in the training. That's the only way we can make the difference. So we are proposing 2 kinds of training on assistive technology. One is more in generic nature, and one is more specific. Generic nature means in a community center, primary healthcare center, a nurse should have the knowledge to give what a right size of crutch, how to give a right walker or a basic type wheelchairs with training. But what she cannot manage there, she can send to many of you who are working at the referral level. And the referral level, people need to have a more knowledge, because our prosthetic orthotics education is still very much prosthetics and orthotics. We don't look much beyond that. But we have to look, time has come. We have to look at wheelchair, we have to look at mobility devices, we have to look at other assistive devices. But when I come to the specialized, we also this specialized training package we do, like wheelchairs, prosthetics, and orthotics. So we'll have a generic training package for the ATP professionals, for generalists, as well as for specialists. So we'll aim that every piano education will have a module on assistive technology in coming years. When we come to the specialized training, we talk about wheelchair. We have done a lot last 5-6 years on wheelchair, from guidelines, basic, intermediate, managers, stakeholders, and we can see the impact. And of course, if you want to know more, you come to the session 68 to learn more about this. And the next, the big one, is also prosthetics and orthotics. In 2005, we developed these guidelines. And these guidelines focused only two things: prosthetic orthotics training, and that to low-income countries or developing countries. But the new one will change the whole sector across the world. It will be a prosthetic orthotics standards for the whole world, and we'll focus on policy, practice, products, and training. And we'll have a consensus conference on this on 9 to 13 September in Maidal, and we expect to launch it on 8th May next South Africa ISPO Congress. So the main purpose is that today, if you see the assistive technology scenario, these are what it exists, mostly in high-income countries. The whole concept of assistive technology certification profession is stuck in very few high-income countries. So time has come to make the dots everywhere. So we are having upcoming events. There are two big events we are coming up. One is the GATE Research Group meeting in 9 September in Budapest, and the GATE Expert Industry Consultation in 29th and 30th October in Beijing. And I think that's all. Thank you very much.
Thank you so much. Now you know why he was invited. Very, very, very nice. Thank you so much.
Thank you, Ben. Should I get it now?
And what do you think? Yes. I think he deserved this more than anybody else. And I'm sure if Knud Jansen, who is the founder of ISPO, have heard this, he would be very, very proud. It's an honor to give you this. Thank you very much.
Thank you.
You also, you're also going to get not water, you're going to get something else here. You get something for the wall. I'm sorry for the bad signature down here. And, and you get a book of Lyon, so you know where you are.
Thank you.
Thank you very much.